Yeah, 3 minutes. 3 minutes time ఉన్నట్టుంది కదా 2-3 అయినా స్లోగా వస్తుంది
కొంచెం లైవ్ 1 minute
ఇది సర్వర్ అంతా యాక్టివ్ ఉన్నట్టు లేదు ఓకే అమ్మా థ్యాంక్ యూ రమ్య Good afternoon. So we are back with the optic nerve. Coming to the amblyoppias, different types of toxic amblyoppias. We now will discuss about the methyl alcohol amblyopia. The cause of methyl alcohol amblyopia is mostly with the industrial workers, and it's a disease, acute form, which can cause optic neuritis and permanent blindness. The etiology is intake of wood alcohol or methylated spirit or any inhalation of the fumes in the industries, and it can be also through the skin absorption. Mostly the inhalation of fumes in industries makes the importance of this topic. Coming to the emergencies, loss of vision, visual emergency at the industrial workers. Coming to the pathogenesis, the methyl alcohol is oxidized to formic acid and formaldehyde, and it causes edema and degeneration of the ganglion cells of the retina, causing optic atrophy and permanent blindness. So the methyl alcohol amblyopia, it is an acute form which causes optic atrophy and permanent blindness, and the etiology is usually through intake of wood alcohol or methylated spirit, and the main etiology is inhalation of fumes in the industries or sometimes through the absorption from the skin. And the pathogenesis is the methyl alcohol is oxidized to formic acid and formaldehyde, which causes edema and degeneration of the ganglion cells of the retina, thus causing optic atrophy and permanent blindness. Coming to the clinical features, it is just like any features of acute poisoning, presenting with nausea, vomiting, headache, dizziness, abdominal pain, delirium, stupor, and death. And the diagnostic feature is the characteristic odor of the formaldehyde in the breath and sweat is a diagnostic feature. So the clinical features are the features of any acute poisoning related, like nausea, vomiting, headache, dizziness, abdominal pain, delirium, stupor, and death. And the characteristic odor of the formaldehyde in breath and sweat is a diagnostic feature. Coming to the ocular features, the patient will be presented with complete blindness. On fundus examination, we'll see the prominent disc edema with attenuation of the vessels, and bilateral primary optic atrophy is seen on the fundus examination. The patient will present with sudden complete Loss of vision presenting as complete blindness. On fundus examination, the patient will be presenting with disc edema and attenuation of the vessels and presenting as bilateral primary optic atrophy. Coming to the treatment part, it is just like handling any acute poisoning case, giving the primary support like gastric lavage and the administration of alkali and ethyl alcohol in early stages is given, which the underlying theory is it prevents oxidation of methanol to formaldehyde, thus stopping the edema of the cells and the peritoneal dialysis. So the treatment is gastric lavage, administration of alkali in early stages. It is ethyl alcohol is substituted, thus preventing the oxidation of methanol and peritoneal dialysis. Coming to the quinine amblyoppias. It may occur with small doses of quinine in susceptible persons. The clinical features are near total blindness, deafness, tinnitus. Fundus will show retinal edema, disc pallor, and the attenuation of the vessels will be seen. And the visual fields is characteristically grossly contracted visual fields are seen. So the quinine amblyopia is seen with even with the small doses of quinine in some susceptible persons, which is the characteristic feature of the quinine amblyopia. And the patient will be presenting with near total blindness, deafness, tinnitus, and on fundus examination there will be retinal edema, disc pallor, and the attenuated blood vessels and the grossly contracted visual fields are the characteristic features. Coming to the ethambutol amblyopia. This is the, what is ethambutol? It is an anti-tuberculous drug which will be causing toxic optic neuritis, and the patient will be presenting with central scotoma. When optic chiasma is involved, the patient will be presenting with bitemporal hemianopia, and even the color vision is impaired. And the beauty of this is the recovery usually follows. The recovery of the visual lost will be recovered after stopping the drug. So the ethambutol amblyopia, it is anti-tuberculous drug which causes toxic optic neuritis, and the patient will be presenting with the central scotoma. When the optic chiasma is involved, the patient will present with bitemporal hemianopia and impaired color vision, and the recovery follows after stopping of the drug. Coming to the anterior ischemic optic neuropathy. What is AION? It usually the present it is produced due to the altitudinal field defects which has complication of seen after severe anemia, any massive hemorrhage or neglected acute attack of angle closure glaucoma will present as AION, that is anterior ischemic optic neuropathy. Etiology, it can be inflammatory and non-inflammatory, and it is AION broadly divided into the arteritic type and non-arteritic type. And other causes are severe anemia, collagen vascular disease, any massive hemorrhage, papilledema, the simple migraine, and the malignant hypertension can also cause AION. Coming to the characteristic features, the patient will present with sudden visual loss, and on fundus examination, we can see the characteristic segmental or diffuse edema of the disc will be seen, and on examination, the disc may be pale or sometimes hyperemic depending on the etiology, and in advanced cases we can see splinter hemorrhages also when the etiology is of vascular origin, and the characteristic visual fields there will be altitudinal hemianopia, that is the upper nasal half field will be defective. In giant cell arteritis, it is the constant headache with pulsations in the temporal artery is the characteristic feature in giant cell arteritis. So coming to the clinical features, it is sudden visual loss. On fundus examination, it present as segmental or diffuse edema of the disc. The disc can be pale or hyperemic depending on the etiology, and when in advanced cases we can see splinter hemorrhages also, and the characteristic visual fields will be defect is altitudinal hemianopia. When the cause of AION is giant cell arteritis, it presents as constant headache with pulsations in the temporal artery. And the loss of vision in one eye or any extraocular muscle palsy will also be seen. Coming to the non-arthritic type, it usually presents as unilateral presentation with altitudinal field defects and disc edema. The non-arthritic type usually is unilateral with altitudinal field defects and disc edema. Coming to the investigations, the ESR is the characteristic feature. There will be raised ESR, and the C-reactive protein is a characteristic diagnostic test in the giant cell arteritis, and FFA in hyperperfusion, any temporal artery biopsy in the giant cell arteritis is seen. The investigations are ESR, C-reactive protein, FFA when there is any hyperperfusion or temporal artery biopsy. Coming to the treatment, usually the heavy doses of corticosteroids is given ranging from 60 to 80 milligram of prednisolone per day and tapered to the 10 milligram per day, and patient is later on put on maintenance dose of 5 milligram per day for a period of 3 months to 1 year is required. So the mainstay of treatment is the corticosteroids, starting with 80 milligram of prednisolone and tapering to the 10 milligram per day and a maintenance dose of 5 milligram per day for over a period of 3 months to the 1 year. So AION, it is mainly with the altitudinal field defects, and usually with the as a sequence of severe anemia or any massive hemorrhage, and the most common cause will be severe anemias or any collagen vascular diseases or malignant hypertension, and the patient presenting with sudden visual loss with segmental or diffuse edema with altitudinal field defects. And if in giant cell arteritis, the pulsating temporal artery associated with constant headache. And the investigations are ESR and C-reactive protein and the temporal artery biopsy, and the steroids are the mainstay of treatment. Coming to the posterior ischemic neuropathy. It is same as AION except for the site of involvement. It usually occurs in the disorders of the plial vessels which supply the intraorbital part of the optic nerve. So coming to the anatomy part of the optic nerve head, where the intraorbital part is supplied by the plial vessels. It is usually commonly seen in systemic lupus erythematosus, vasculitis, or any giant cell arteritis. So it is same like the AION except the site of involvement will be different, and it usually occurs with the disorders of the plial vessels which supply the intraorbital part of the optic nerve, and it is commonly seen in SLE, vasculitis, and the giant cell arteritis. And the clinical features are there will be afferent pupillary defect, no fundus finding, and the treatment is also same as AION, that is the steroids are the mainstay of treatment. Coming with starting with the 80 milligram per day and tapering to the 10 milligrams and putting the patient on 5 milligram per day on a maintenance dose up to 3 months to 1 year. So the PION is same like AION except the SLE is the main cause and there will be no fundus findings. That is the main difference because the disorder will be in the plial vessels. Coming to the traumatic optic neuropathy. It is of two types, direct and indirect. The direct is less common and anatomical disruption of optic nerve in the cranioorbital trauma is the main cause. The direct traumatic optic neuropathy is less common and it is due to the direct and anatomical disruption of the optic nerve in the cranioorbital trauma. The indirect one, it usually occurs with the closed head injury due to the avulsion of the nutrient artery or by the pressure affected transmitted to the through the optic canal. So the indirect is seen in the closed head injury usually due to the effect of pressure effect because the optic canal cannot be stretched beyond so the pressure directly is carried on to the optic nerve causing the avulsion of the nutrient vessels thus affecting the nerve. Coming to the characteristic features. Mainly there will be loss of vision or sometimes decreased vision will be seen and dilatation of the pupil on the affected side will be characteristic feature and there will be loss of direct pupillary right reflex on the affected side with preservation of the ipsilateral congenial light reflex and vice versa. So coming to the congenial light reflex will be present when the other side of the tract is good due to the and RAPD is the first sign and there will be preservation of the near reflex due to the presence of the congenial light reflex and the visual fields will be typical with presenting with central and the centrocecal scotomas will be seen on the visual fields and the treatment is but the steroid and in emergency cases it is the surgical decompression. So the characteristic feature is the loss of vision or the decreased vision, the dilatation of the pupil and the loss of direct pupillary right reflex on the affected side with the preservation of the ipsilateral congenial light reflex and the vice versa. And the RAPD is the first sign and the near reflex will be preserved and the characteristic visual fields like central and centrocecal scotomas are characteristic and the treatment is steroid and in emergency cases it is the surgical decompression. Coming to the important topic of papilledema. Papilledema it is sometimes given as SC question so you have to be thorough with papilledema. And it is also one of the major conditions seen in emergencies and other various systemic diseases. So papilledema is very important topic. Coming to the papilledema. What is definition of papilledema? It is nothing but it is the edema of the optic disc or the nerve or due to the raised intracranial pressures. So papilledema is defined as edema of optic disc or nerve head due to the raised intracranial pressures. Causes. It can be pseudopapilledema, papillitis, neuroretinitis. Coming to the ocular causes, it can be a consequences of the complications presenting due to uveitis, any hypertony or vein occlusion. So the causes is pseudopapilledema, papillitis, later on developing as papilledema, neuroretinitis or ocular. It is mainly with the uveitis, any hypotony or vein occlusion can produce papilledema. Coming to the orbital causes. Mostly it is pressure related or any tumors in the surrounding vicinity, or graves of ophthalmopathy or orbital cellulitis, or some of the causes of orbital. Mostly the graves of ophthalmopathy or any inflammatory condition like orbital cellulitis or tumors can cause papilledema. Coming to the vascular causes, the main common cause is the anemia, any uremia or any AION can present with papilledema. Now coming to the causes of papilledema, secondary to the raised intracranial tension, it can again be divided into congenital or any space occupying lesions. It is the congenital is any defects what we have seen in the anatomical part in the orbital anatomy, any aqueductal stenosis or any craniocentosis. This malalignment of the fusion of the cranial sutures causing craniocentosis or any congenital anomalies like aqueductal stenosis can cause pressure on the nerve and thus causing papilledema. Coming to the intraocular intracranial space occupying lesions, the main stay is the brain tumors or any abscess, tuberculomas, gamma or any subdural hematoma can also cause papilledema. So the space occupying lesions can be brain tumors, abscesses, tuberculomas, gamma or the subdural hematoma. Coming to the intracranial infections. It can be meningitis, encephalitis or any intracranial hemorrhages like subarachnoid hemorrhage, any obstruction of the CSF absorption or any tumors of the spinal cord or idiopathic intracranial hypertension or any systemic malignant hypertension or PIH or diffuse cerebral edema or some of the other causes of papilledema. Coming to the disc swelling due to ocular or orbital lesions or can be unilateral or any raised ICT, the papilledema will be presenting as bilateral papilledema will be seen or and the other cause of unilateral disc edema with raised ICT is the Foster Kennedy syndrome, which is olfactory and sphenoidal meningioma with associated with frontal lobe tumors, which will present as optic atrophy on one side and papilledema on the other side. In Foster Kennedy syndrome, it is the olfactory and sphenoidal meningioma with frontal lobe tumors, which will present optic atrophy on one side and papilledema on the other side, is the characteristic feature of the Foster Kennedy syndrome. Coming to the pseudo-Foster Kennedy syndrome, it is unilateral papilledema with a raised ICT and a pre-existing optic atrophy. Coming to the pathogenesis. There are various theories as being put forward. The most accepted theory is the Harris theory, where it presents as the papilledema is developed not due to the pressure, but it is due to the stasis of axoplasma in the prelamellar region of the optic disc due to the alteration of the pressure gradient. This is the Harris theory, which proves that there is stasis of the axoplasm in the prelamellar region of the optic disc, thus causing the alteration of the pressure gradient, thus causing axonal swelling in the prelaminar region, which in turn causes venous congestion and the extracellular edema. So the main pathogenesis is proved by the Harris theory. It is most accepted, which is with the basic principle is the stasis in the oxoplasma in the prelaminar regions, thus causing the optic disc difference in the optic disc, causing the axonal swelling in the prelamellar lesions, thus causing venous congestion and the extracellular edema. The papilledema thus mainly results from the compression of the central retinal vein by the raised cerebrospinal fluid pressure around optic nerve. Coming to the clinical features. The main clinical features are the patient will be usually presenting with headache, nausea, and the projectile vomitings will be seen, which is the characteristic feature of raised ICT. The projectile vomitings is the characteristic feature of the raised ICD, and often the patient will be presenting with diplopia. And other commonest cause clinical feature or ocular clinical feature is amaurosis fugax. What is amaurosis fugax? It is nothing but transient loss of vision will be seen, um, and the visual acuity remains normal in the till late stages. Only a transient loss of vision will be seen, which is coined as amaurosis fugax, and the patient will be having generalized headache with nausea and projectile vomitings, later on diplopia. Coming to the early or incipient papilledema, the symptoms will be absent and normal visual acuity will be seen, and the pupillary reflexes are normal. The fundus findings, there will be obscuration of the disc edema, usually following in the first order, following ISNT, like the nasal margins followed by superior, inferior, and the temporal margins, which is different from the glaucomatous disc edema. Here, the obscuration of the disc margins. First, the nasal margins will be followed, lost, followed by the superior, inferior, and the temporal margins. And there will be blurred NFL layer will be blurred, and there will be absence of spontaneous venous pulsation, and there will be hyperemia of the disc with splinter hemorrhages, and characteristically the visual fields will be normal. Coming to the established papilledema. It is transient visual loss in one or both eyes. The pupillary reactions will be normal, and on fundus examination there will be disc edema with raised elevations of the retina, with obliteration of the physiological cup will be seen, and the hyperemic disc with blurred margins are seen. So in the established papilledema, there will be transient visual loss in one or both eyes, where the pupillary reactions will be normal. On fundus examination, there will be raised, the disc will be raised, usually pertaining to 1 to 2 millimeters of retina, and there will be obliteration of visuological cup disc ratio will be lost, and there is hyperemic disc with blurred margins. And you can also see multiple soft exudates and superficial hemorrhages will be seen, and the veins will be tortuous and atrophied, and there will be grayish white retinal folds will be seen, and the hard exudates will be present. There will be multiple soft exudates and hard exudate with superficial hemorrhages and tortuous veins, and grayish white retinal fields on chronic edema, and the visual fields there will be enlargement of the blind spot. Coming to the chronic papilledema. The visual acuity is severely reduced, and the pupillary reactions will be normal. On fundus examination, we will see acute hemorrhages and resolved exudates with reabsorbing papilledema, and the characteristic champion croc appearance of the disc is the characteristic feature of the chronic papilledema. And we can see corpora ameliaceae. What is corpora ameliaceae? It is nothing but a crystal deposits or brucines on the disc. And the visual fields will see enlargement of the blind spot will be seen, and there will be constriction of the visual fields will be starting. Coming to the atrophic papilledema. Here, the visual loss will be very severe and the light reflex will be also be impaired. On fundus examination, the characteristic grayish-white disc appearance is the characteristic of atrophic papilledema, and raised ICT, raised disc, which is seen as the persistent intracranial tension will be raised, so it presents as raised disc. Coming to the retinal artery, it is narrowed and the retinal veins are congested and the seething of the vessels will develop and the visual fields will see the concentric contraction of the peripheral fields are seen. So the retinal arteries will be narrowed and the retinal veins will be congested and the sheathing of the vessels will develop and the visual fields, the concentric contraction of the peripheral fields will be seen. So coming to the atrophic papilledema, the visual loss will be very severe. The light reflex will also be lost. On fundus examination, the characteristic grayish-white disc will be seen and there will be raised disc which is associated due to the raised intracranial tension and the retinal arteries will be narrow, sheathing of the vessels will develop but the retinal veins will be congested and the characteristic visual fields you see the contraction of the peripheral fields is seen. The differential diagnosis we have to differentiate from the pseudopapilledema and the papillitis. Coming to the treatment, it is a neurological emergency and patient usually has to undergo cerebral decompression.